All right, this slide is your big picture timeline. Think of it as the Google Maps view of human development before we zoom into specific disorders and disruptions. We're not memorizing this list for fun, although I know that's disappointing. We're using it to understand when things go wrong, why they go wrong, and what tissues and systems are most vulnerable at different times. Fertilization. This is where everything begins. The embryonal period. This is the most critical window in development. The fetal period. Now we're past basic organ formation and into growth and maturation. Number 4, perinatal period. This is the transition phase. Late pregnancy through shortly after birth. Sorry about that, my dryer went off. Infancy, rapid growth. Everything is still learning how to function independently. Childhood, growth continues, systems stabilize, and the body gets better at maintenance and repair. And lastly, adolescence. Hormones enter the chat. As we move through genetic and developmental disorders, always ask yourself, when did this start? Because timing explains everything: severity, presentation, and long-term outcomes. And yes, this slide looks simple, but it quietly explains about 80% of developmental pathology. Fertilization is beautifully simple on paper. Egg plus sperm equals zygote. That's it. That's the tweet. But under the hood, absolute chaos. Thousands of sperm, one winner, and a highly choreographed molecular handshake that ensures the correct chromosome number, no extra guests, polyspermy equals a bad party, and activation of embryonic development. From a histotech perspective, this is the moment where the genome is set, imprinting patterns are locked in, and mitochondrial DNA is entirely maternal. Dads, sorry, your mitochondria do not survive this relationship. Fun fact, mitochondria were once free-living bacteria, so technically every cell in your body contains ancient freeloaders that just refuse to leave. And this is the high-stakes phase of development. The embryonal period covers the first 8 weeks after fertilization. And during this time, cells are dividing rapidly, tissues are differentiating, organs are being laid down, not refined, but established. This is why this stage is extremely sensitive to nutritional deficiencies, drugs and medications, chemicals, toxins, and radiation. If something goes wrong here, you don't usually get subtle changes. You get major structural anomalies or pregnancy loss. This is also why most spontaneous abortions due to chromosomal abnormalities happen during this window. The system does a quality check and sometimes fails fast. The embryo is basically saying, if we're doing this, we're doing it right, or we're not doing it at all. Once we hit the fetal period from 8 weeks to birth, the blueprint is already in place. Now it's all about growth, refinement, functional maturity. Organs like the lungs, kidneys, liver, and brain take the longest to mature, which is why prematurity hits these systems the hardest. A quick terminology reminder, because medicine loves confusing people: 38 weeks equals time from fertilization. 40 weeks equals gestational age, counted from the last menstrual period. Same pregnancy, different math, everyone's annoyed. From a pathology standpoint, this period explains why some exposures cause growth restriction rather than malformations, why late-stage insults affect function more than structure, and why timing is everything when interpreting congenital disease. The brain is still developing well into your 20s, which explains, well, a lot of human behavior, including some questionable decisions. Okay, so let's zoom in on the perinatal period, which is basically the body's way of saying things are about to get real. The perinatal period spans 2 weeks before birth through 4 weeks after birth. This window is clinically important because it's where a lot of critical transitions happen and where things can go sideways quickly if systems aren't ready. You'll also hear the term neonatal period, which overlaps a bit. Neonatal specifically refers to birth through 4 weeks after birth. So think of neonatal as a subset of the perinatal window. The big headline here is adjustment to life outside the womb. Lungs turning on, circulation rerouting, thermoregulation kicking in, and metabolism suddenly having to pull its own weight. At birth, fetal circulation shuts down three major shunts: the ductus arteriosus, the foramen ovale, and the ductus venosus. If those don't close properly, you'll absolutely hear about it later in pathology. From here, we shift into the post-neonatal development stages, starting with infancy. Infancy runs from 1 month to 1 year of age, and this is a period of explosive growth, physically and neurologically and immunologically. Motor skills develop fast, the brain is wiring at lightning speed, and the immune system is basically attending boot camp. Next up is childhood, which spans from end of infancy to the onset of puberty. This phase is about refinement, better motor coordination, cognitive development, and increasing physiological stability. Then we hit adolescence, the final developmental stage before aging begins. Hormonal shifts dominate here, leading to sexual maturation, growth spurts, and, let's be honest, a lot of metabolic chaos. The prefrontal cortex, which controls impulse regulation and decision making, is one of the last brain regions to fully mature, often well into the mid-20s. So yes, science does explain a lot. Now let's pivot to congenital defects, which is where development and pathology really intersect. Congenital defects result from events occurring during either the embryonic or the fetal period. These defects can be caused by genetic factors, environmental influences, or very commonly, a combination of both. Maternal disease can interfere with enteroplacental blood flow, leading to stunted growth or even intrauterine fetal demise. Intrauterine infections can directly damage fetal tissues, especially during periods of rapid cell division. Structural problems also matter. Abnormalities of the umbilical cord can jeopardize oxygen and nutrient delivery, and amniotic bands can physically restrict or distort developing limbs or organs, leading to asymmetric defects. Many congenital abnormalities aren't obvious grossly, but become apparent histologically. Altered tissue architecture, delayed maturation, or abnormal differentiation patterns are common findings. This slide sets us up to focus specifically on environmental contributors to congenital malformations. While genetics load the gun, environmental factors often pull the trigger. Timing, exposure level, and duration all matter. The key takeaway here is that developing tissues are highly sensitive, especially during the embryonic period when organ systems are forming. The same exposure that might be harmless later can be devastating early on. This is why embryology is so clinically relevant. It explains why certain defects occur when they do. Okay, now we shift gears from genes and chromosomes to something equally powerful, the environment. Because even with a perfectly normal genome, development can still go sideways if the conditions are wrong at the wrong time. That's where tetragens come in. Tetragens is anything that interferes with normal development of an embryo or fetus. Key idea here, and this will absolutely show up on exams or board certifications. Timing matters more than dose. A small exposure at the wrong developmental stage can be far more damaging than a larger exposure later on. Infectious agents. Certain infections can cross the placenta and directly affect developing tissues. Classic examples include viruses and parasites that disrupt brain development, vision and hearing, and cardiac formation. These agents don't just cause inflammation, they alter cell differentiation and organ patterning. Drugs. This includes both pharmaceutical and recreational drugs, and yes, biology does not care whether the drug was prescribed or borrowed from a friend. Some drugs interfere with DNA synthesis, cell division, and vascular development. If you ever hear it's safe because it's natural, that's a red flag, not reassurance. Maternal health factors. The fetus is completely dependent on the maternal environment, so maternal health matters a lot. Diabetes mellitus can alter nutrient delivery and growth signals, leading to abnormal fetal size or organ development. Nutrition is another big one. Deficiencies like folate can cause neural tube defects. Excesses can be just as harmful. Worthless knowledge moment here. Folate deficiency doesn't damage the neural tube. It prevents it from closing in the first place. That's a constriction problem. That's a construction problem, not a repair issue. Physical factors. This category includes radiation, hypothermia. Yes, high fevers count. Environmental exposures. Rapidly dividing cells are especially sensitive here, which is why early embryonic tissues are most at risk. Histology tie-in, the faster the mitotic rate, the higher the vulnerability. Environmental chemicals, these are substances that interfere with hormonal signaling, enzyme activity, or gene expression. Some act as endocrine disruptors, meaning they mimic or block hormones at exactly the wrong time in development. And the tricky part, the damage may not show up until years later. So the big picture takeaway is environmental factors don't change the DNA sequence, but they absolutely change how that DNA is expressed. So when we talk about congenital abnormalities, remember this. Genetics loads the gun, environment pulls the trigger. That metaphor is dramatic, but unfortunately accurate. All right, histotechs, welcome to the club nobody wants to join, TORCH infections. TORCH isn't a fancy acronym to impress your friends. It's a reminder that mild mom symptoms can equal major fetal consequences. Here's the unfair part. The mother may have something that looks like a bad cold, a mild rash, or nothing at all, and meanwhile the pathogen casually strolls across the placenta like it owns the place. Quick refresher without the baby level review. Toxoplasmosis, yes, cats get blamed, but undercooked meat is the real MVP here. Other would be syphilis, Hep B, HIV, basically the infectious wild cards. Rubella, mostly historical because vaccines work. Imagine that. CMV, cytomegalovirus, the most common congenital viral infection and criminally underappreciated. And then we have the herpes virus, which shows up again later with a vengeance. So clinically, TORCH infections love the brain, eyes, liver, spleen, and heart because rapidly dividing tissues are like an all-you-can-eat buffet for pathogens. TORCH infections are one of the reasons placentas get sent to pathology even when the baby looks okay, because pathology often sees what pediatrics can't yet. Now we're going to talk about infections that occur around the time of birth, which is what perinatal and neonatal mean. This is a period when the immune system is basically still in beta testing mode, so infections that might be mild in adults can be devastating in newborns. Herpes simplex virus, HSV1 or HSV2. Yes, this is the same herpes virus we talk about in adults, but the stakes here are much higher. Neonates usually acquire HSV during delivery through contact with infected genital secretions, less commonly in utero or postnatally. And here's the scary part. The mother may be asymptomatic, so there's no obvious warning sign. So localized infection affects the skin, eyes, and mouth. This is often abbreviated as SEM disease. So skin will have vascular lesions, tiny fluid-filled blisters. The eyes will have conjunctivitis or keratitis. In the mouth, ulcerations. If you ever see multinucleated giant cells with nuclear inclusions on a snack smear, HSV should be screaming in your head. Fun but not fun fact, HSV vesicles look small and innocent. They are not innocent. Disseminated infection. This is where things escalate very quickly. HSV can spread systematically and cause encephalitis, which is brain inflammation, hepatitis, which is liver failure, and pneumonia. At this stage, the virus isn't just infecting cells, it's destroying organs. Some worthless knowledge that actually becomes useful later. Neonatal HSV encephalitis has a predilection for the temporal lobes, just like in adults. Why this matters clinically: neonatal HSV has high morbidity, high mortality, and often long-term neurologic damage, even with treatment. That's why early recognition and rapid antiviral therapy is absolutely critical. So, big picture takeaway: newborns don't get the luxury of a mild case. In the neonatal period, small infection is equal to big consequences. Localized disease can become systemic fast. Early diagnosis is literally life-saving, or as I like to summarize it, in neonates, viruses don't wait around to see how things go. All right, let's continue with perinatal and neonatal infections, and this time we're zooming in on neonatal conjunctivitis, also known as ophthalmia neonatorium. And yes, this is one of those topics where the picture does a lot of the talking. What is neonatal conjunctivitis? Neonatal conjunctivitis is eye inflammation that develops within the first month of life, usually from exposure to infectious organisms during passage through the birth canal. Newborns' eyes are delicate and immunologically immature, and extremely unforgiving when infection sets in. So, translation: this can go bad quickly if not treated. The big players for common causes you need to remember are chlamydia trachomatis, most common cause in the U.S. Symptoms usually appear 5 to 14 days after birth. It's characterized by redness, swelling, and mucopurulent discharge. Histotec pearl here is chlamydia is obligate intracellular, so think inclusion bodies, not something you're going to culture like your average bacteria. Neisseria gonorrhea, this one is the true emergency. Symptoms appear within 2 to 5 days after birth. Causes: profuse purulent discharge, severe eyelid swelling, and rapid corneal damage. Without treatment, this can lead to blindness. Before routine eye prophylaxis, gonorrheal conjunctivitis was a major cause of childhood blindness. Other STIs are less common but still possible. Herpes simplex virus, other bacterial pathogens. These tend to vary in severity but should never be brushed off as just eye irritation. This is why newborns receive routine antibiotic eye prophylaxis shortly after birth. It's not overkill, it's prevention. So, key takeaway for your future pathology brains: timing of onset plus type of discharge equals huge diagnostic clue. Neonatal conjunctivitis isn't just pink eye in a baby. It's a sentinel sign of maternal infection, a preventable cause of permanent vision loss, and a reminder that birth is not a sterile event. Or put more bluntly, newborns don't need a lot of exposure to get into serious trouble. Ah, yes, thalidomide, the pharmaceutical equivalent of "we didn't test this enough." Prescribed in the 50s and 60s for morning sickness, it gave us limb truncations, cardiac defects, internal organ malformations, and permanently changed drug regulation worldwide. One drug, one error, massive policy overhaul. Other tetragens you should absolutely recognize: retinoic acid, amazing for acne, disastrous for embryos; warfarin, fantastic anticoagulant, terrible fetal architecture; ACE inhibitors, kidneys really don't appreciate these during development. Tetragenicity isn't about dose alone, it's about timing. The same exposure at different developmental windows can mean no effect, minor anomaly, or catastrophic malformation. Thalidomide is still used today for cancer and autoimmune diseases under some of the strictest prescribing protocols in medicine. Ending strong with fetal alcohol syndrome, which is entirely preventable and entirely unforgiving. Alcohol crosses the placenta easily and disrupts neural crest cell migration, brain development, and growth signaling pathways. The result: growth restriction, neurodevelopmental impairment, and those classic facial features: long, fat philtrum, which is the vertical groove between the nose and the upper lip; the telecanthus, increased distance between the inner corners of the eyes without the eyes themselves being too far apart; and mild ptosis, which is drooping of the upper eyelid. And here's the hard truth: there is no safe amount of alcohol during pregnancy. Not just one glass. Alcohol doesn't just cause growth malformations, it alters cellular architecture and brain organization in ways that aren't always visible at birth, but show up later in cognition and behavior. Fetal alcohol syndrome is one of the leading preventable causes of intellectual disability worldwide, and yet still completely avoidable. Maternal diabetes affects fetal development in ways that seem counterintuitive at first. Rather than growth restricted, we often see macrosomia, and that's driven by fetal physiology, not maternal size. Macrosomia means a baby that is abnormally large at birth, typically defined as a birth weight greater than 4,000 to 4,500 grams, so about 9 to 10 pounds. Most commonly associated with maternal diabetes is gestational diabetes. It's caused by excess glucose crossing the placenta, which makes the fetus produce more insulin, which increase fat and body size. A histotech-friendly way to think about it is too much sugar in mom, baby acts like it's in a constant growth mode. Maternal hyperglycemia leads to fetal hyperglycemia, which triggers fetal pancreatic hyperplasia and chronic hyperinsulinemia. Insulin in this context acts as a powerful growth factor. That's why these infants are often large with increased adipose tissue, acromegaly, and a high risk of birth injury. But here's the catch. Despite being large, these infants can be functionally immature, especially in the lungs. After birth, the sudden loss of maternal glucose can result in neonatal hypoglycemia, which is why close monitoring is critical. Expect increased fat deposition, enlarged organs, and occasionally delayed pulmonary maturation in severe cases. These babies are sometimes described as big butt brittle, which sounds rude, but clinically captures the problem pretty well. Iodine deficiency is less common in developed countries, but when it occurs, the effects are profound. Iodine is required for thyroid hormone synthesis, and thyroid hormone is essential for normal brain development, especially in the first trimester. When maternal iodine is deficient, the fetus may develop congenital hypothyroidism, historically referred to as cretinism. The consequences aren't subtle: intellectual disability, growth retardation, and hearing or speech impairment. This is exactly why congenital hypothyroidism is part of newborn screening. Early thyroid hormone replacement dramatically improves outcomes. Unlike many congenital conditions, this one is largely preventable with adequate maternal nutrition. Iodized salts has likely prevented more intellectual disabilities worldwide than any pharmaceutical drug in history. Not flashy, but wildly effective. All right. If you remember nothing else from this slide, remember this. Congenital heart defects are the most common embryonic anomalies. Not rare, not exotic, but common. So if something goes sideways during early development, the heart is often the first organ to raise its hand and say, hey, something didn't quite go as planned. Congenital heart defects equal most common embryonic anomalies. The heart starts forming very early. We're talking weeks 3 to 8 of embryonic development, which is prime time for things to go wrong if genes, oxygen, blood flow, or environmental factors are off. So translation is early structure plus complex folding plus multiple moving parts equals higher chance of error. The most common congenital malformation is the bicuspid aortic valve. Normally, the aortic valve has 3 cusps. In a bicuspid aortic valve, it only has 2. This might sound minor. What's one missing flap? But over time, this can cause turbulent blood flow, early valve degeneration, and aortic stenosis or regurgitation later in life. Many people with a bicuspid aortic valve don't know they have it until adulthood. It's often discovered incidentally during imaging or surgery. So yes, you can walk around for decades with a heart valve that's slightly freelancing. Cyanotic heart defects. It's something that sounds scary, especially the word cyanotic, right? Cyanotic heart defects are congenital cardiac anomalies that result in cyanosis, meaning the baby appears blue due to poor oxygenation of the blood. This happens when oxygen-poor blood mixes with oxygen-rich blood, or blood bypasses the lungs entirely. Think of it like staining. If oxygen is your dye, cyanotic defects mean the stain never fully reaches the tissue. Let's walk through these examples shown on the slide. No panic, just patterns. So we have patent foramen ovale, or PFO, a normal fetal opening that fails to close after birth. We have coarctation of the aorta, a narrowed segment of the aorta. Think of a kinked hose. Patent ductus arteriosus, or PDA, is another fetal structure that should close but doesn't, causing abnormal blood flow. And then the tetralogy of Fallot, the classic cyanotic defect, 4 problems bundled into one. Ventricular septal defect, pulmonary stenosis, overriding aorta, and right ventricular hypertrophy. Good news, most of these can be repaired surgically. Here's the hopeful part, and yes, I like ending on hopeful. Most congenital heart defects can be repaired surgically. Sorry, I already said that. Modern pediatric cardiology and cardiac surgery are honestly amazing. Early diagnosis, imaging, and intervention have drastically improved outcomes. So a big picture takeaway, these defects are common, serious, but often fixable, especially when identified early. So heart defects equals most common embryonic anomalies. Bicuspid aortic valve is the most common congenital malformation. Cyanotic defects is poor oxygenation, which equals blue appearance. Many defects are surgically correctable. This slide is terminology heavy, but each term describes a specific failure in development. Spina bifida results from failure of neural tube closure. Syndactyly reflects incomplete separation of digits. Polydactyly involves extra digit formation, often genetically influenced. Agenesis refers to complete absence of an organ due to failure of development. And then there's Meckel diverticulum, which is essentially a remnant of the embryonic connection between the intestine and the yolk sac. Most people with Meckel diverticulum are asymptomatic, but when it causes problems, it really causes problems. Meckel diverticulum can contain atopic gastric or pancreatic tissue, which means unexpected acid secretion in the small intestine. Chaos ensues. Meckel diverticulum follows the rule of twos, which everyone pretends to remember perfectly. Okay, let's talk about a fetal disease that sounds terrifying because honestly, it kind of is. But once you break it down, the mechanism is actually very logical. Erythroblastosis fetalis, also known as hemolytic disease of the newborn. This is a classic example of the immune system doing exactly what it's designed to do, just against the wrong target. What's the core problem? In erythroblastosis fetalis, maternal antibodies cross the placenta and attack fetal red blood cells. The key idea is that mom's immune system recognizes something on the baby's red blood cells as foreign and decides to go to war. The most common scenario involves Rh incompatibility. Mom is Rh negative, baby is Rh positive. How this happens? During a prior pregnancy or delivery, fetal Rh positive red blood cells enter maternal circulation. Mom's immune system says absolutely not and makes anti-Rh antibodies. In a subsequent pregnancy, those antibodies cross the placenta. They bind to fetal red blood cells and cause hemolysis. This is antibody-mediated destruction of red blood cells, classic immune hemolysis. When fetal red blood cells are destroyed, the fetus develops severe anemia. The bone marrow starts pumping out immature red blood cells to compensate, hence the name erythroblastosis. Several cases can lead to heart failure, hydrops fetalis, and stillbirth. Which brings us to the last bullet, life-threatening. And yes, that's not an exaggeration. Without intervention, erythroblastosis fetalis can be fatal. The good news, this condition is now largely preventable. Administration of RHO-D immune globulin, or RHO-GAM, to Rh negative mothers prevents antibody formation, one of the biggest wins in preventative medicine. This is not a genetic disease. It's an immune-mediated hemolytic process. The placenta is the delivery system for the antibodies. Prevention is key. Once antibodies exist, the risk escalates. This slide is a bit of a grab bag: infections, nutrition, blood flow, and neurologic outcomes, but the unifying theme is placental health and fetal vulnerability. If the placenta is compromised, the fetus pays the price. Chorioamnionitis, first up. This is an infection of the placental membranes, especially the chorion and the amnion. This is not a mild inflammation we ignore. This is a medical emergency. Why is it such a big deal? Because infection in the membranes can trigger premature delivery, neonatal sepsis, convulsions, and even death. In other words, once bacteria gets access to the amniotic environment, things escalate quickly. Inflammation plus infection plus developing organs equals a very bad combination. Next, nutritional deficiencies, specifically iron, iodine, and folate. These nutrients are essential for oxygen delivery, brain development, and DNA synthesis and cell division. So when they're deficient, growth and development suffer. Folate deficiency is why folic acid supplementation became a public health standard, because neural tube defects are largely preventable. Impaired blood flow to the placenta. Anything that reduces placental blood flow reduces oxygen, nutrients, waste removal. A major contributor here, cigarette smoke. Nicotine causes vasoconstriction, meaning narrowed placental vessels, less blood reaching the fetus, and lower birth weight and higher complication risk. If the placenta can't deliver, the fetus can't thrive. Finally, cerebral palsy. This is a non-progressive disorder of muscle coordination. Important word here, non-progressive. That means the brain injury does not worsen over time, but the functional effects persist. Some associated risk factors are low birth weight, intrauterine infection, placental disorders, and multiple gestations, so twins, triplets, etc. Cerebral palsy is not always caused by birth trauma. Prenatal factors play a major role. Across this entire slide, infection, poor nutrition, reduced blood flow all disrupt normal fetal development, often through placental dysfunction. The placenta is not just a passive structure, it's the lifeline. Now we shift into the perinatal period, which is roughly late pregnancy through the first week of life. And this is where prematurity dominates the conversation. Prematurity is defined as birth before 37 weeks, and it's the single most important cause of disease during this period. About 10% of babies are born prematurely, so this is not rare. It's common enough that every hospital deals with it regularly. Prematurity correlates strongly with low birth weight, which then cascades into a long list of complications. Immature lungs mean hyaline membrane disease. Fragile vessels in the brain mean intracranial hemorrhage. Immature immune systems mean sepsis. You'll also see intestinal infections, particularly necrotizing enterocolitis, and abnormal retinal development, which is why oxygen therapy in preemies is a carefully balanced act. From a lab perspective, these patients generate a lot of specimens, blood cultures, placentas, sometimes autopsy tissue, and context is everything. Gestational age changes how you interpret findings. Prematurity isn't just small baby, it's organ systems being asked to function before they finish developing. This slide shifts us from fetal pathology into infancy, which is an important distinction. Once a baby is born, the rules change. Physiology changes, exposures change, and so do the risks. 5 major causes of infant death. This list is one that you'll see again in pathology, autopsy, and public health context, so it's worth committing to memory, not just for exams, but for real-world understanding. Number 1, congenital and chromosomal abnormalities. First, congenital and chromosomal abnormalities. These are structural or genetic tissues that develop before birth, may be incompatible with life, or cause severe physiologic compromise after delivery. This includes things like trisomies, major cardiac defects, and neural tube defects, many of which we've already discussed. Number 2, prematurity and low birth weight. Premature infants aren't just small, they're unfinished. Common problems include immature lungs, poor thermoregulation, underdeveloped immune systems. Even with modern NICU care, prematurity remains a leading cause of infant mortality. Number 3, sudden infant death syndrome, or SIDS. This is defined as sudden unexplained death in an apparently healthy infant, usually during sleep. SIDS is a diagnosis of exclusion, meaning everything else has to be ruled out first. We don't fully understand the mechanism, but risk reduction strategies do save lives. Number 4, complications of maternal diseases. Conditions like diabetes, hypertension, infections, and substance use disorders can all affect fetal and infant health, sometimes long after delivery. Many of these effects trace back to placental pathology, not just the baby itself. And number 5, diseases of the placenta, cord, and membranes. This is very important. Issues here include placental insufficiency, cord compression or knots, and infections of membranes. If oxygen or nutrients are interrupted, the infant may not survive, even if everything else is structurally normal. Big takeaway, a healthy baby requires a healthy placenta. The bottom line, infant mortality is rarely caused by a single factor. It's usually the result of developmental issues, maternal health, and placental function, as well as timing. Too early, too fragile. Infants are particularly vulnerable to infection because maternal antibodies only provided protection for about 6 months. After that, the immune system is on its own training wheels. Iron deficiency is one of the most common nutritional problems worldwide and can impact cognitive development if not addressed early. Again, not flashy, but incredibly important. We also need to talk about accidents and injuries, including shaken baby syndrome. This is a form of abusive head trauma that results in intracranial hemorrhage, retinal hemorrhages, and often devastating neurological injury. It's uncomfortable to discuss, but necessary. Globally, infection and malnutrition remain the leading causes of infant death. This isn't a failure of biology, it's a failure of access, resources, and prevention. This is one of those moments where pathology intersects very directly with ethics and advocacy. As children grow, the disease landscape changes again. In childhood and adolescence, accidents and infections become more common causes of morbidity and mortality. Kids explore, teens test limits, biology responds accordingly. What's notably uncommon in this age group? Degenerative diseases and neoplasms. Cancer happens in children, yes, but it's rare compared to adults, and it behaves differently. From a lab standpoint, pediatric pathology often requires a different mindset. You're not just shrinking adult disease down to size, you're dealing with conditions shaped by growth, development, and time. Children are not just small adults, and anyone who's worked in pediatric pathology learned that the hard way. And finally, we land on genetic disease detection and testing, where all of this starts coming full circle. Testing isn't limited to chromosomal diseases anymore. We can routinely evaluate embryonic anomalies, fetal diseases, and even subtle structural abnormalities using a combination of cytogenetics, molecular testing, and histopathology. This is where histotechnology quietly plays a huge role. Good tissue processing, proper fixation, and clean sectioning matter because downstream testing depends on it. Genetic testing also raises important conversations about consent, counseling, and interpretation. A result without context can be harmful, which is why collaboration between clinicians, genetic counselors, and the lab is critical. Now that we've talked about what chromosomal diseases are and what they look like, let's talk about how we actually detect them. And spoiler alert, it's usually not just one test. First, many chromosomal abnormalities are suspected clinically. This means the provider notices characteristic physical features. Growth patterns or congenital anomalies raise red flags. Physical exam raises suspicion, but it does not confirm a diagnosis. Think of it as, something doesn't add up here. Karyotyping can confirm a diagnosis. And this is where we move from suspicion to confirmation. Karyotyping visually analyzes chromosomes. It confirms extra missing or structurally abnormal chromosomes. This is literally chromosome photography. Arrested cells, stained chromosomes, lined up like a yearbook photo. Then we have maternal serum screening. This is not diagnostic. It estimates risk, not certainty. Screening looks for markers associated with neural tube defects, trisomy 21, and it triple screens. So it measures AFP, which is alpha-fetoprotein, HCG, and esterol. Quad screen measures AFP, HCG, esterol, and inhibin A. Quad screen is just the triple screen that said, let's add one more for better accuracy. And finally, we have amniocentesis. This is a diagnostic test, not just screening. It involves sampling amniotic fluid, analyzing fetal cells, and performing karyotyping. Big distinction to remember, screening equals risk estimate, amniocentesis equals confirmation. Yes, it's invasive, but it provides definitive answers. A big picture takeaway, detection of chromosomal disease usually follows this path. Clinical suspicion, screening to estimate risk, and then diagnostic testing to confirm. Or in plain English, we notice, we screen, we prove it. When we're talking about embryonic anomalies and fetal disease, detection usually isn't just one thing, it's layered. We start with the basics, a physical exam. That might be prenatal or postnatal, but sometimes the clues are subtle and sometimes they're very obvious. Radiologic procedures are especially helpful for skeletal abnormalities. Bone doesn't lie. If something didn't form correctly, imaging will show it. Ultrasound is a big player here. It's non-invasive and incredibly informative. Things like hydrocephalus, polycystic kidneys, and congenital heart defects can often be identified this way. Exploratory surgery sounds dramatic, and it is, but sometimes it is necessary to confirm or correct anomalies. And finally, cultures and serology help us identify infectious causes. Remember, not all fetal disease is genetic. Some of it is microbial and opportunistic. This slide adds a few more tools to the diagnostic toolbox. Antigen testing becomes important in immunologic conditions, so Rh incompatibility is the classic example. This is one of those areas where early detection can prevent serious downstream damage. Placental evaluation is hugely underrated. The placenta tells a story about oxygenation, infection, inflammation, and timing. That's why it's recommended in cases of prematurity or delivery complications. And then we have biochemical diseases, which are often picked up through newborn screening rather than prenatal testing. Conditions like sickle cell anemia, PKU, galactosemia, and congenital hypothyroidism don't always announce themselves at birth, but they absolutely matter long term. As histotechnologists, we may not diagnose these directly, but we absolutely support the process. Fun fact, PKU was one of the first genetic disorders shown to be treatable through diet, which completely changed how medicine thought about inherited disease. Just to remind you, PKU is a genetic metabolic disorder where the body cannot properly break down phenylalanine, an amino acid found in protein-containing foods. Think of it as phenylalanine is garbage, the enzyme is the trash truck, and in PKU, the trash truck never shows up. Now let's talk specimens, our comfort zone. Amniocentesis involves sampling amniotic fluid surrounding the fetus. That fluid contains fetal cells, which means we can perform karyotyping and biochemical testing. It's also used to detect neural tube defects, often through elevated alpha-fetoprotein levels. Then there's chorionic villus sampling, or placental biopsy. Instead of waiting for amniotic fluid, we can sample placental tissue directly. This allows earlier detection of chromosomal and DNA abnormalities. Different specimen, different timing, same goal. Information that helps guide care. Chorionic villi are fetal tissue, not maternal, which is why they're so diagnostically valuable. Both increase risk of spontaneous abortion, though. This is one of the most impactful public health tools we have. Newborn screening is typically done after 24 hours, but before 7 days of life. Timing matters because metabolism needs to turn on before abnormalities can be detected. That heel stick blood spot might look simple, but it screens for dozens of serious conditions. Metabolic disorders, hemoglobin pathopathies, endocrine tissues, and more. The key idea here is early detection equals early intervention. Many of these diseases are devastating if untreated, but manageable if caught early. This is preventative medicine at its best. The APGAR score is quick, simple, and sometimes misunderstood. It's done at 1 minute and 5 minutes after birth and evaluates 5 things: activity, pulse, grimace, appearance, and respiration. This is not a long-term prognosis, it's a snapshot, a how are we doing right now assessment. A low score doesn't mean permanent damage, and a high score doesn't guarantee a perfect future. It just tells the delivery team whether immediate intervention is needed. No baby is getting a college scholarship based on their APGAR score. It's strictly a moment in time evaluation. Now that brings us to the end. You survived, I survived, everyone wins. If you take nothing else from this lecture, remember this. Developmental and genetic diseases aren't just about chromosomes or enzymes. They're about timing, detection, and intervention. And as histotechnologists, even when we're not the ones making the diagnosis, we're part of the chain that makes diagnosis possible. If questions pop up later, and they usually do, feel free to email me or use Canvas. And please don't wait until 11:59 p.m. unless you enjoy stress.